Okay, well, hello and welcome. Thank you for joining us for our Facebook Live seminar. Today we're joined by Dr. Brandon Scharer, foot and ankle surgeon with Orthopedics and Sports Medicine Baycare Clinic. He's here today to discuss ankle stability issues and what treatment options are available for patients, including total ankle replacement. Thanks for joining us today, Dr. Scharer. Before we get started, I want to thank everyone for tuning in. As you can see, Dr. Scharer and I are taking precautions to remain socially distanced in the wake of the current pandemic. We're joining from separate locations and we are being safe. Before I turn things over to Dr. Scharer, I want to remind everyone, if you do have any questions for Dr. Scharer about ankle stability issues or questions about specific treatment options, feel free to ask them in the comments below. We will do our best to answer your questions today in real time. If we run out of time, please continue to ask questions. We'll answer those questions online after the live broadcast. Okay, well, without further ado, I will turn things over to you, Dr. Scharer, to get us started today.
All right, thank you, Alicia, and I'd like to thank everyone for joining us tonight. Again, my name is Brandon Scharer. I'm a foot and ankle surgeon at Baycare Clinic Orthopedics, and today we're going to be talking about ankle instability and total ankle replacement. Sorry about that. So first off, we'll kind of give you a little bit about my background. I did my residency training in Milwaukee at St. Joseph's Hospital, and then did an AO fellowship with Sigfrid Hansen. He's kind of a world-renowned foot and ankle surgeon in Seattle. Now is retired, but a big part of that fellowship was a total ankle replacement. And I've been working here at Baycare Orthopedics for the last 6 years and practicing in the area for approximately 10. So these are the locations I service. Green Bay is my hub, kind of the main location. That's where I live, and then I do outreach to Marinette and then as well as Kaukauna. As far as Kaukauna goes, this is our new clinic location, just opened up a couple weeks ago. It's a 72,000 square foot ambulatory surgery. It's basically a medical center with a surgery center, urgent care, medical office buildings. We have multiple specialties there. We have on-site CT, rehab, physical therapy. So pretty a comprehensive location located right off the highway of 41 and 55 in Kaukauna. This is a list of the providers we have through the Baycare Clinic. So we have ear, nose, and throat, audiology, cardiology, our whole orthopedic service line there. We have a hand surgeon, Dr. Klicka, Dr. Olson as well, who's more of a general orthopedist, myself, Dr. Schock, and then our nurse practitioners and PAs. Dr. Schock practices sports medicine. And then the rest of the list on there as well. So first we're going to talk about ankle arthritis. What is ankle arthritis? It's basically a loss of smooth cartilage between the bones and the joint. There's many stages to arthritis. There's three main types. Primary is kind of your wear and tear arthritis, a lot of times seen in the hip and the knee. Systemic arthritis is more your rheumatoid or psoriatic arthritis, many times seen in the hand and the foot. Post-traumatic arthritis, which we'll be focusing on, mostly affects the ankle. About 75% of all ankle arthritis is a result of either some type of sprain or some major injury. As far as ankle injuries, they're very common. You got a lot of statistics here, but as you can see, just over 150 hospitalizations a year just due to ankle fractures. I'm sure a lot of these numbers are low, they're just estimates, but very, very, very significant ankle injuries. As far as the prevalence of ankle arthritis itself, injuries to the ankle are 10 times more prevalent than hip injuries, although they're about 8 to 10 times less. Arthritis in those joints are 8 to 10 times less in the ankle. So although the ankle's injured much more, there's usually less arthritis in the hip and the knee. So again, 75%, 80% is mostly due to post-traumatic arthritis. So what does it look like? Many times it's clinically, the patient will present, it's swollen, it's painful, they have limited motion, sometimes they'll have some clicking and grinding in the joint. Many times we'll start with an x-ray followed by maybe an MRI or a CT to just further evaluate that joint. As far as preventing ankle arthritis, trying to avoid ankle sprains or ankle fractures, sometimes that's not so easy. But if you do have a bad ankle fracture or bad injury, to have it hopefully fixed and evaluated by someone that does ankle surgery. So if you put it back together appropriately, there's a lot less chance that you're going to develop ankle arthritis down the road. Treatment options range from conservative all the way to surgical options, which would be more your fusion or ankle replacement. As far as conservative options, anti-inflammatories, many patients have tried before they come into the office. Immobilization, which would be a brace, many times that's been tried prior to seeing me. Orthotics or other types of immobilization devices. Physical therapies can sometimes be helpful, particularly water therapy. And then something that we can perform in clinic is cortisone injections, which are also very helpful. PRP injections, stem cell injections, we also offer in our clinic by Dr. Woods, and those are also good options. As far as early ankle arthritis, that's where we kind of see some spurring kind of in the front of the joint. And a lot of times we can remove those through a scope. So a simple surgical procedure, just like you're scoping our knee, to kind of remove some of that early arthritis. As far as, when the arthritis starts to advance, you get that bone-on-bone arthritis, you have a couple options, either fusion or replacement. Fusion is where you just remove the joint and weld it together, like that top right picture there. Or you just replace the joint totally, like the image just below that. So equally, they both can, give you pain relief. Both have similar complication rates. The ankle replacement in the past has been higher, but now recently it seems like it's been coming down with the new implants. So a fusion, what's the benefit of a fusion? Historically, it's been the kind of the gold standard. It will last forever if it fuses. You can do that procedure in many different deformities or medical conditions. There's definitely fewer restrictions when it comes to age, weight, and medical comorbidities. The downside is now you're locking up the ankle, so there's other joints that are going to have to take up that loss of motion, and those joints will kind of wear out prematurely. And the last thing you want to do is fuse those joints, because you'll end up with a very stiff foot. So when it comes to fusion, it's still an excellent option, because there's just some people that just can't have replacement for multiple reasons. But you'll be very surprised that patients do function very well with an ankle replacement. Many times you could walk two patients down the hall, one with a fusion, one with a replacement. You have a hard time telling who had which procedure. So replacement, definitely the pro is you have more normal motion. It's easier on the surrounding joints. You don't have to worry about arthritis in those joints in the future. Definitely becoming more common. We're doing more and more in the practice, just for the fact the implants have definitely improved over the years. Eventually it'll wear out. Some of the literature isn't totally up to date in the fact that we just don't have a lot of literature on some of the more recent and more advanced implants. But typically I tell patients 15 years, 9 years is the literature, but I really think it's more closer to 15. And that all depends on activity, age and weight and all those things as well. So definitely my preference, definitely the focus of the fellowship, even if the implant fails, we have more and more options to revise that. So again, they're getting to be much more improved. So, early on, they were definitely prone to failure. Nowadays, we have a lot better implants. This is the implant I mostly use. It's a CT guided implant. So basically what we do is we get a CT scan prior to surgery. The engineers then will design these guides specific to that patient's anatomy. We open the ankle up in the surgery. We put those on, cut the bad bone out, tamp the implant in, and it's very, very quick, which gets us out of the operating room, decreases the risk of infection, increases our chance of a good placed implant. So the ideal patient, somebody older than 55, less than 250 pounds, minimally deformed, and low activity. We always say golf is maybe the ideal activity level. But over the years, these have changed too. We've done them in younger patients than that, and definitely patients that have weighed more than that, and they've done very well. So every year it seems to be a little bit better. We're pushing the limits a little bit more, and we're seeing better results. As far as replacement, other considerations, you got to look at the other joints, the condition of the ankle itself, the position of the foot. There's a lot of different things you got to look at. It's just not ankle pain and you automatically get a replacement. But many times if it's ankle arthritis, we can replace it. So here's a good patient, 67-year-old male, had previous hip and shoulder replacement. As you can see on the images on the lower left, he's got essentially bone-on-bone arthritis, significant spurring. That image in the middle is actually an MRI just showing the damage and the cyst formation in the joint. And then the other images on the right-hand side, those are showing the implant and how much space you have in there, and that implant will be pain-free and glide nicely. Another one, 62-year-old male or female, post-traumatic arthritis, severe ankle fracture, as you can see. But as you can see on the bottom images there, you can see how before the implant, there was significant impingement, bone on bone in the front where the ankle couldn't even move upward. And once you get the replacement in there, it moves more normally. So final thoughts, ankle arthritis definitely is debilitating. I see these patients every day. And they're not living a fun life many times. And many times it's not their fault. Some of these injuries, they just happen, that you can't prevent them. And, if they develop severe arthritis, ankle replacement or even fusion is definitely a good way to eliminate symptoms. It's definitely become more accepted. It's kind of the standard of care now. Even I've been practicing in 10 years, and it's amazing how things have progressed. So it seems like every year seems to be getting better, and the comfort and training for myself, and I'm sure other surgeons, has gotten a lot better as well. Any questions on that first topic?
I think you covered it a little bit, Dr. Scharer, but one of the questions that came up was maybe some of the common causes of this. And I know you said that they're not necessarily specific causes, but what have you seen from injury-wise? What can cause this type of ankle arthritis?
The biggest one is, bad ankle fracture. And even in the best hands, you can only put those back together so well. So anytime you fracture through the joint and you damage that cartilage, it's never going to be normal again. So any bad ankle fracture. The next topic we're going to talk about is chronic ankle instability. These are individuals that just have a lot of instability and they've sprained the ankle multiple times. Well, every time you sprain that ankle, the cartilage basically gets damaged. And every time you do that, then the cartilage wears away and it becomes arthritic. So those are definitely the two most common. Other ways could be, deformity. A lot of patients come in with certain deformities and it wears out the ankle prematurely. So there's a variety of reasons, but definitely the injury is the most common.
Interesting. Another question, and this may be something that you'll get to a little bit later, but are there exercises or strengthening exercises that you can recommend as maybe some sort of conservative method prior to maybe this replacement?
Yeah, a lot of sometimes it's not necessarily going to be the motion that you want, because a lot of that motion is painful. So that's why we start to recommend bracing. Even an over-the-counter athletic brace, you wear that and put it in your shoe, it'll limit some of the motion and some of the laxity in the joint, and that'll hopefully relieve some of your symptoms. But yeah, there's just not a lot of activities once arthritis sets into the joint.
Excellent. Okay, I think we can move forward.
Perfect, thank you. So the next topic, we're going to talk about ankle instability. First, we'll talk about, just acute ankle sprains, and then we'll kind of jump into chronic ankle instability. So as far as statistics for ankle sprains, they constitute approximately 85% of all ankle injuries, and 85% of those are an inversion sprain. And what that is like the gal in the middle there, that she's turning her ankle. That's where the ankle turns inward. That's definitely the most common way of spraining your ankle. And there's a lot of lost sports because of these ankle sprains. The mechanism of injury, again, is inversion. So another easy way to see it is with the basketball player here, and it doesn't always have to be sports related. It can be anything. It could be dancing at a wedding or missing the step, going down the stairs. It could be a variety of reasons. So the presentation of a sprain, most people have seen these or know somebody or has had a sprain: swelling, bruising, pain. Sometimes you can put weight on it, sometimes you can't, depending on the severity. Typically you'll start with just maybe throwing some ice on it, elevating, maybe putting an ace bandage on it. If it gets evaluated by someone in the ER urgent care, many times they'll put you in one of these boots or even start some physical therapy. The biggest thing with a bad ankle sprain is to get it evaluated, because it's not always an ankle sprain. Many times patients come in with crutches and they have a bruised ankle and they say, well, I think I just sprained my ankle, and then we take an x-ray and they have either a metatarsal fracture which is caused by that same type of injury. And sometimes those surgically need to be treated. The biggest one, I think, is an ankle fracture. An ankle sprain and an ankle fracture many times are the same injury. They present the same, and we get an x-ray and you have this severe fracture. And then in that case, it has to be surgically fixed. If this were something that you just kind of pushed through and didn't have it fixed, you definitely develop severe arthritis very, very quickly. Another one is some of these smaller ones is a calcaneal fracture. Same exact injury, same presentation. Many times I've seen these patients and we think we're dealing with an ankle sprain. Later on, get an MRI or a CT scan and it shows that we have this little fracture that is sometimes difficult to get to heal without some surgical repair. Another common one, so anytime you turn that ankle turns inward, the two bones in the joint hit, and you can break off portions of that talus, or what they call the tibia, in the joint, and that little piece of bone acts as gravel in the joint. And unless you get that out surgically, that can create significant damage to your joint and cause ankle arthritis as well. So that was more of an acute sprain or injury. The next thing we're going to talk about is chronic ankle instability. So these are patients that have sprained the ankle many times in the past. They had that first sprain, it probably tore the ligaments on the outside of the ankle. Well, now that ankle's loose and it continues to sprain over and over again. Usually the patient presents with pain, a history of multiple sprains, and the biggest one is they say, my ankle it'll give out on me periodically. I can be walking down the hall, it just gives out on me, just feels unstable. So in clinic, a lot of times we'll start with x-rays and we'll manipulate the ankle under x-ray. And many times it almost feels like you could dislocate the ankle just in clinic because they're so unstable and loose. It's seen in these pictures kind of in the center there. So usually after that, then we'll get an MRI and that'll further evaluate the ligaments, the tendons around the ankle, as well as the joint itself. So treatment's simple: continued long-term bracing, surgical stabilization, really physical therapy. If you have true functional instability in the ankles, physical therapy is going to be tough to take care of that. So then we start talking about treatment. In my practice, there's two approaches. One is an open approach and one is an arthroscopic approach. So there's three main ligaments in the ankle. The top one there is the anterior talofibular ligament. That's in the front. That's the most commonly injured. Then we have the calcaneal fibular ligament, which is just lower to that. That's the second most common. And then the posterior talofibular ligament, which is very rarely torn. So to repair this, it's a simple procedure. We open it up and we're basically taking those ligaments, repairing them, taking the tissue in front of it and just tightening it up so this ankle doesn't give out on that patient again. So the open repair looks like this. Incision, we open it up, we suture it back together and we close it up. It's a fairly large incision. Post-operatively for these patients, they're non-weight bearing in a cast for about 6 weeks. Then we start some physical therapy, get them in a boot, and usually resume sporting activities around the 3 to 6 month mark. Arthroscopically, this is just a picture of an arthroscope. It's much smaller incisions. We're just making basically 3 tiny incisions to scope the ankle and then repair the ligaments. So this is just a picture of the inside of the ankle joint. This is a picture of the patient in surgery. You can see how small that incision is in comparison to the previous one we just showed you. This is just a picture here of the one on the left, which is the patient that has significant instability. This is just post-operatively right after the repair. Both of these are being stressed. So we're turning the ankle inward. And you see how much tighter the one is on the right. And also you can see the incisions, very, very small, very minimally invasive. So post-operative care with the arthroscopic repair, we can be a little bit more aggressive with these patients. We're not devitalizing as much tissue, less dissection, so we get them on their foot a little bit quicker. So 2 weeks, typically non-weight bearing, and then we'll get them in a boot for another 4. Back to most activities, walking activities at 6 weeks, and then usually sporting activities for sure at about 3 months with and without bracing. As far as research on this, myself and one of my partners in 2019, we in the Journal of Foot and Ankle Surgery, we actually compared this and looked at ankle stabilization with the scope, the arthroscopic approach versus the open approach. And we really found similar procedure time between the two. Definitely less postoperative swelling and pain with the arthroscopic group. When we looked at it at a year and 18 months, very similar result. Patients were usually doing very, very well with a stable ankle. Biggest thing though that we noticed was that with the arthroscopic group, we could get the patients walking on it 4 weeks earlier. So for a lot of patients, that's a big thing to not have to use crutches for 4 weeks less, or an e-scooter or something like that. So that was kind of the big one that we pulled out of our research. So final thoughts on ankle instability. Ankle sprains and instability is very, very common. It's a huge portion of my practice just because it's that common. Conservative care should definitely be attempted first. If the ankle is truly unstable, stabilization of the ankle will likely be needed. Whether you have this done through the open or arthroscopic approach, both options are good. But the arthroscopic, procedure, if it can be done in the patient, definitely it seems to be a benefit, particularly in my practice. And that's it on ankle instability. Any questions?
Yeah, I wanted to touch on it just a little bit more if we could, Dr. Scharer. You had mentioned the arthroscopic being maybe the one that is primarily done in your practice, but is there a better candidate for one over the other, or does someone make more ideal candidate for one procedure?
So the arthroscopic patient is usually the individual that has less maybe instability in the ankle. A lot of times if we're repairing tendons, based on what we're seeing on the MRI, maybe we'll do the open approach because we're opening it up anyways. Sometimes we'll base it on weight, where we'll do more of the open approach. Patients that have already had stabilization, we're not going to go in there and do an arthroscopic approach. We're going to do an open approach. So not all patients are a candidate for the arthroscopic approach, but it's usually that more mild to moderate ankle sprainer that mainly just has ankle instability, not much else going on.
Interesting. One of the questions that I wanted to ask is the difference maybe between acute and chronic, and when maybe you make that distinction that this is maybe more of a chronic issue than maybe something that's one time.
Yeah. So, I would define more of a chronic ankle sprain as someone that's sprained it more than once, and is dealing with instability. Whereas someone that has an acute sprain, many times the patient that has a sprain, if you put them in a boot early on, those ligaments will scar down and they won't end up having any instability. So, a sprain is definitely different than someone that's a chronic ankle sprainer or has instability.
Interesting. And I know you discussed it as well, but I want to talk just a little bit. These are outpatient procedures. Talk a little bit about the length of time spent and that kind of thing, and maybe the safety that people might be concerned with now, just given the current situation.
Yeah, so we'll start with ankle fusion are all outpatient. We don't keep anybody in the hospital for an ankle fusion. Outpatient surgery, you go home the same day, pretty quick and easy. Ankle replacement, we do those also. Patients can go home the same day depending on their insurance. Some of the insurances make the patient stay overnight in the hospital and some don't. As far as all the ankle stabilization procedures and scopes and all those procedures, all of those are done outpatient, go home the same day.
Fantastic. We did have a question from one of our viewers just about the fusion in general. And I know you talked a little bit about the motion post-procedure, what that's like. What kind of motion do they have? Are they still able to drive a car, say, if the fusion happened on their right foot?
Absolutely. You can still drive a car. There's still quite a bit of motion there. So you still have the kind of the inward outward motion of your foot. Your foot's still going to go, upward, downward, which we call dorsiflexion, plantar flexion. Like I said before, it's tough to tell when patients have an ankle fusion and they're walking down the hallway or you see them walking down the street. It's tough to tell if they have a fusion or not. That's how well they function.
Fantastic. The last question that I wanted to touch on is, and you talked about this too, but if someone is experiencing ankle issues, what is your advice? What are their next steps?
Well, I guess it depends if it's something that obviously just started, sometimes and there's no injury, maybe give it a little bit of time. But If it's an acute injury, definitely get it evaluated either through maybe an urgent care if it's very acute, or make an appointment with one of us to take a look at it. You don't need a referral to see any of our providers in our clinic. You can just make an appointment to come in. And basically we'll start usually with an x-ray and examination and go from there.
Fantastic. Well, thank you, Dr. Scharer. Is there anything else that you want to add?
I think we're good.
Excellent.
Thanks.
Thank you so much for talking with us today and sharing this insight. I think it's very valuable. Thank you again, all of you who are watching. If you do have additional questions for Dr. Scharer, please continue to ask them in the comments below. We will do our best to continue answering those questions online. Again, Dr. Brandon Scharer is a foot and ankle surgeon with Orthopedics and Sports Medicine Baycare Clinic. To learn more or to request an appointment, visit baycare.net. Thank you. Have a great evening.